Happy Wednesday. I'm doing fine. I wonder how many people I scared away. Well, it's a difficult test because of the cardiac stuff. But once again, I'd like to think that you're all sitting somewhere comfortably with a pencil and paper or a pen and paper or something with my slides downloaded, like 3 to a page, if you can do that, printed, or just, again, take notes. So when I say this is going to be on the test, I'm not kidding. It's going to be on the test. And so there should have been no surprises on that exam. Everything on that exam I told you was going to be on the exam. But again, if you don't write it down, you couldn't type fast enough. Remember, you don't need complete sentences. It's not an English class, so all you need was a quick bullet statements, and you could abbreviate quite a bit. And like I said, I really don't take off for spelling, but I'll have all the tests graded, and we'll go over it on Monday. Okay. And once again, well, we'll talk about it on Monday, because there's quite a few of you that had technical issues, and that's not going to be sustainable. But we'll talk about that on Monday. All right. And once again, folks, this isn't a history class. You can't just sit there and say, phew, I'm glad I'm done with all that endocrine and cardiac stuff. Because no, we're going to build on that. So obviously the blood vessels are part of the cardiovascular system, and you'll have to remember a lot of the cardiac as well as the neurotransmitters and hormones. So again, this stuff just keeps piling on. So with that said, let's move on to the vascular system. And again, we're just knocking this out. So we just got done with the heart. We'll cover blood vessels today. And then on Monday, we'll be on the blood, and then we can put it all together. So some of these slides you've already seen before. So again, we have the pulmonary and systemic circuit. So some of these things I'm just going to go through quickly. On your last test, you were responsible for the major arteries and veins coming directly off the heart, and that will be the same for this. So you're going to be tested twice. So on the next test, you'll have to tell me about the pulmonary trunk, the pulmonary arteries, and veins. Now, I go through a lot of this stuff real quickly as far as the anatomy. Primarily, I just go over how you pronounce these things, because again, you'll use your handout from the lab and all the photographs of all the models you have to identify the vessels that the lab handout requires, right? So everything on the lab handout except for what, somebody? Very good. And I will tell you the ones that I want you to know. There's like 1 or 2 in this presentation that you have to know, but they're super easy, very easy. All right, so there's just an overview of the systemic circulation, and those are pretty much all the arteries that you need to know. And we're going to cover these in a little bit more detail. So this is kind of an overview. And again, I try to remind myself that you're not really completely familiar with how the circulatory system works. So you have arteries. The very large ones come right off the heart or the aorta. And they branch, and they branch, and they branch until we get to the smallest, and that is the arterioles. Amy, you'll need to refresh. No, she can't hear me. Okay. Thank you, guys. Good teamwork there. Good teamwork. All right, so where was I? Okay, yeah, so the arteries branch into really small arteries called arterioles. They branch and branch until we get to capillaries, and this is where the action happens. If you remember, the capillaries are very thin. Somebody remind me what kind of tissue make up our capillaries? Very good, Christine. Excellent. All right. So they're very thin, simple squamous, but a half a millionth of a meter thick, so easy for things to be exchanged, i.e. oxygen, CO2, nutrients, and whatnot. We'll talk more about that. Then the capillaries come back together to form small veins called venules, and those will merge back together to form veins. So our basic anatomy of a blood vessel, very simple, right? You have an inner lining called the tunica intima or interna. You can use either one. Interna is probably a little bit easier because it's referring to internally. So it's the lining, and it is composed of just simple squamous epithelium. So one thin layer make up the tunica intima. The tunica media has the smooth muscle, and this smooth muscle is responsible for vasoconstriction and vasodilation, and we're going to be talking a lot about that today. And then we have the tunica externa, which is just, again, the lining of connective tissue. And so the space inside is called the lumen. I'm thinking we used that word before, so it's good. And this is just a slide that you can use along with your lab handout and PowerPoint photographs of the models, but it's very simple, very simple. And you just have to know the tunica intima, media, and externa. Don't worry about the other smaller layers within the tunica intima. I'm not going to ask you about endothelium, subendothelial, or internal elastic membrane. I'm not going to ask you anything. All right. So here is the start of one of your big essay questions. Did everybody hear me? One of your big essay questions, and I'll talk very slowly, is to describe what I call form following function. Form following function. Who can tell me what that means? Form follows function. No one? No one's ever heard that before? Diani? Never heard that before? Okay, Daniel. That's pretty good, but you kind of got it backwards. Okay? So it should have been the function dictates the structure. Okay? Meaning, yeah, these vessels have functions, and so the structure assists in that or facilitates that function. And so this is just the first slide. There are probably 4 or 5 slides in here that you can put together to give me a cohesive answer. So, boom, you have question 1 already, or the start of question 1. And here is the only slide that you need to know for the lab practical. All right? And it's pretty straightforward. You can see that the tunica media is much, much thicker than the externa or interna, because that's where all the muscle is. All right? Now, I'm going to say something here. People always get this confused here. All right. Notice the artery is nice and, well, it's a little oval, but almost round. The vein is all kind of scrunched up. Does anybody know why that is? Anyone want to take a wild guess? No one wants to guess. Okay, again, this is just a little gee whiz thing. You probably, inspiration, all right. So, this is just your little histology lesson. If you want to make a slide of something, you embed it in either wax or plastic to harden it, and then you slice it with a very sharp knife, we would call a microtome, to make very, very thin slices. But because the vein is thinner, you can see the difference in the thickness of the vein and the artery, okay? When they make that slice, the vein is kind of like trying to cut a warm loaf of bread. Everybody with me? Everybody know what I'm talking about? Yeah, it gets kind of squished, all right? So my point is it doesn't, so because people put this on the test, and at first I thought it was just, that's funny. So when I asked you about the differences between an artery and a vein, somebody put, the veins are squishy. And I'm like, no, the veins aren't squished, all right? In your body, the vein would be nice and round, all right? This is all because it got cut with the knife. All right, so that's the only histology slide you need to know. All right, so let's go through this. We have our arteries. We have the real large ones, and it starts with the aorta, coming right off the heart, and then we're going to have major branches. Most of these branches are pretty large too, and they're very elastic. They're elastic, and I will cover this 3 or 4 times because, again, this is part and parcel to what I want you guys to understand when we talk about cardiovascular disease. All right? So I'm going to say this 3 or 4 times during this lecture. They're called elastic arteries because when that left ventricle contracts and we eject that blood out of the ventricle into the aorta, and here I'm just going to mess with somebody. Christine Bandela, how much blood is going to be ejected out of that ventricle into the aorta? How much blood on average?
Said 5 liters.
How much?
5.
Whoa. Let's take a step back. I mean, per contraction. Every time the left ventricle contracts, how much blood is going to be ejected? Anybody can help her. See, this is what I'm talking about, folks. Come on, somebody. What's my stroke volume? Okay. All right, that's better. All right. So yeah, on average, 70. Okay, Sydney plays it safe and gives me 50 to 100, which technically would be correct. Deani's going with the higher end. So our average is 70. And but yeah, if you have an itty bitty heart, it could be 50. If you have a great big heart, it could be 100. So what's my point? Well, that's quite a bit of blood if you know your metric system. And so it's going to stretch that aorta. So it's going to stretch like a balloon. And then it's going to contract, recoil, if you will, and shoot the blood forward. Andy, why isn't the blood going to go back into the ventricle? That aorta is going to contract and then, expand and then recoil, shoot the blood forward, but it's not going to go backwards. It's not going to go back in the left ventricle. Why? Anybody want to help Andy? The valve closes? Really, that's the best we can do is the valve closes? Nothing. Nobody can. Oh, goodness gracious. All right. No, oh, come on, folks. Oh, goodness gracious. The ventricle does not pump backward. Now, this has, okay. Where's the AV valve? We need to go over the cardiac stuff again. When the left ventricle contracts, what valve does it go through to get to the aorta? Somebody gave me half of it, but Gabriella was the closest, and Cindy, but what little part of that is missing? No one? All right. I'm not going to drag this out. I was looking for the aortic semilunar valve. And folks, like I said, this is not a history class. Don't think that you're going to forget all the stuff on the heart because we're done with that unit. All right? So we need to envision that left ventricle contracts, forces the blood. And simple questions that we went over. How much pressure do I need to open up that aortic semilunar valve? Somebody? All right, Cindy, great job. All right, good. 81. So yeah, it's going to push it all out. It's not going to stop at 81, and we know it's going to go to 120. Then the aortic semilunar valve is going to close. Right? And when it closes, it makes a sound. Remember? So the blood can't go back into the ventricle. It has to move forward. So, folks, as we go through this course, I'm going to be asking questions over the previous material that we have covered and tested on because it's all related. So, yes, the aorta expands, it recoils because it has a lot of elasticity. And when it recoils, the blood can only go forward, and it's going to go into the major arteries that branch off the aorta that we're going to learn about. Okay. The major arteries, the elastic arteries, will branch out into the muscular arteries. And again, this is where a lot of the, what we call redistributing of blood through vasoconstriction and vasodilation. So once again, and it's going to be like this, it's going to be a long plod if you don't remember anything. So who do I pick on? Let's see here. I want to pick on somebody that's not talking. I know who's talking and who's not. So let's see here. Who haven't I seen? Jessica, Jeremy. Jessica. Can you hear me, Jessica? All right, so here's your question. After 10 or 15 seconds, if she doesn't answer, somebody please chime in. You are a team. So, Jessica, under sympathetic influence, fight or flight, where do I want most of my blood to go? Okay, somebody. All right, very good, Natalia. The skeletal muscles, very good, Bukola. All right, where don't I need it to go? Really? Did you guys say you don't need blood to your heart in a sympathetic response? That would be bear. That would be horrible. You have to fight the bear. Okay, I'm pretty sure, Sarah, I understood what you're trying to say, but come on, folks. What am I looking for? Okay, now you guys are being silly. The brain, so I don't want any blood to go to my brain or my heart if I have to fight. Okay, Joshua, you're onto something. So again, I don't need blood to go to my viscera, my digestive system, my kidneys. All right? So, sorry, I'm not laughing at you. I just think it's funny when you say heart and brain, because that means every time you had a sympathetic response, you just drop dead, which may be your defensive response. Okay. Let's move on, shall we? Again, we branch, and now we have the arterioles. And again, they have all three layers, and they have the smooth muscle. And again, they're going to help control where the blood goes. This is a cool slide here up in the right-hand corner. Capillaries are small. So your average red blood cell is 8 microns, 8 millionths of a meter. And the capillary is just large enough for them to eke by one at a time. Single file. And why do I want that to happen? Somebody? Why at the capillary? We're at the tissues now. Why do I want my red blood cells to go single file? All right, Daniel comes up with the one-word answer. Okay. I mean, you're there, Daniel. But again, I want single file so that each red blood cell can give off their oxygen to the tissues. If you had a whole bunch of them, some of them may not have a chance to diffuse, as Daniel was alluding to. All right, beautiful. And again, even these can be controlled with little sphincters. And again, the word sphincter means probably one thing to the average person on the street. But again, in A&P, a sphincter just means a circular muscle that is used to control movements. All right, so we use these little sphincters to control where the blood goes as well. A little side note that may be a bonus question, hint, hint. You have vasa vasorum, which are itty-bitty blood vessels, capillaries, within the artery so that they can feed the artery itself. Because again, the aorta is considered an organ. It needs blood, it needs oxygen. So yeah, so you have capillaries that actually feed the larger arteries. And again, don't make a big deal. I'm not going to ask you about a meta-arterial or pre-capillary sphincter. That's just to show you that we have this ability to shut blood flow off to areas where we don't need it, especially for the fight or flight. So if I need a sympathetic response for the fight the bear or run from the bear, I don't need, so this would be an example of what the digestive system would look like, or the kidneys would look like. All right, a little bit more about the capillaries. Capillaries have several different variations on permeability, how much stuff leaks out of them. All right, so if you look here at this picture, you can see that a capillary, it's simple squamous, as somebody said, but there's crevices, clefts, there's pores called fenestrations. Fenestra is Latin and Italian for window. So these are large pores where stuff can leak out, and things do leak out of these capillaries. We'll talk more about that later. So we have three basic types of capillaries. They're continuous, which means they're pretty sealed. These permeable, okay? And that's what we have in our skin or muscles. We don't want things to be leaking out, even though it does to some extent. All right? Oops, excuse me. Then we have the fenestrated capillaries. And these are larger because I want a lot of exchange going on. So these will be found at the kidney, and this will make more sense when we talk about the kidney and the digestive system. So we want these to be pretty leaky. And then you see the sinusoidals, which have lots of huge gaps in them. We find these in the liver, bone, marrow, and spleen. I can't really ask this question, so I'll just give you the answer. Why would I want these large sinusoidal capillaries when I'm talking about the bone marrow? Somebody put that together? You should know this. What's going on in the bone marrow? Very good, Setish. Yeah, we're making red blood cells, and we need to be able to get those red blood cells out of the bone marrow and into the circulatory system. We'll talk more about that in a little while when we talk about the spleen and the liver. But yeah, red blood cells need to be able to pass from the bone marrow into the circulatory system. Same thing with the liver and the spleen, which we'll explain later. All right. Boom. Veins. All right. Again, don't try to memorize these numbers. I'm not going to ask you what the size of a vein or a venule is. The big thing is they all have the same three types of layers. And we're good. We're taking a look. What? Question? Okay, I thought somebody said something. All right, so we're taking a little departure to talk about some unique routes other than the pulmonary and systemic. All right, so we have the coronary circulation, which you guys should be familiar with now. We'll also have to talk about the cerebral and the hepatic portal system. So again, coronary circulation we've already discussed. And so once again, you're still responsible for the major arteries and veins that you did in the last unit. And it looks like most of you did okay on that. And that's fine. So I'm not going to go over that. All right, here's a good study slide. So now we have what's called the cerebral arterial circle, otherwise known as the circle of Willis. Guess why it's called the circle of Willis, Joshua? Very good. Very good. Yeah. Mr. or Dr. Willis, I don't know, but you know, I'm not into people's names because it doesn't tell you. Very good, Bukola. But like I said, I'm not into people's names because it doesn't tell you anything. Cerebral arterial circle does tell you exactly what it does. So this is a unique thing. So if you can see my cursor, there's a circle here. It goes all the way around and it's all connected. All right. And what would be the significance, the importance, the benefit of having a circle in your brain? All right. Sarish puts a one-word answer out there. You want to elaborate there? I mean, you got a good answer there, but explain. Okay, Diani also gives me a 2. Very good, Saresh. All right, okay, good. Between Diani, Saresh, and Tolani, I hope everybody else understands what they're talking about here. Yeah, if you get a part of any one of these arteries blocked, what do we call that when we block a cerebral artery? Somebody? Simple word, simple word. What do we call it when we block a cerebral artery? Okay, good. That's what a stroke is. That's what a stroke is. We just block blood flow to a part of the brain. So the cerebral arterial circular is an attempt to avoid that. So if any part of this gets blocked, the blood can go the other way. So like when you have a detour, you're driving and it says road blocked, take this exit or whatever. And so, yeah. Does that make sense to everybody? So again, you get a block here, I'm going to go around the other way. Okay. Cindy says it almost forms a person. You mean the visual image? Okay. Yeah, you have to have a little bit of imagination, but I can see what you're saying. Yeah, that's good. So on your lab handout, it will tell you which of these arteries that make up the cerebral circle that you need to know. Okay, let's move on. Now we have portal systems. And they're called portal because, as I said before, the normal flow that's written down here is heart, arteries, arterioles, capillaries, venules, veins, back to the heart. A portal system has two capillary beds. So we go arteries, arterioles, capillaries, converge back to veins, but then they branch out to form a secondary capillary bed. They come back together to form veins. So boom, I have a portal system. Now the one that you were responsible for is what's called a hepatic portal system. Now, I don't want to get everybody too pumped up, but if you didn't know this, when you eat something and you digest it and it goes into your bloodstream, it's going to be picked up by the arteries in the stomach and the intestine. It's going to go into the bloodstream. The bloodstream is going to send it directly to your liver. Your liver has first crack at everything that you digest. First crack. Meaning everything that you digested and absorbed is going to go to the liver, and the liver is going to do its thing. We'll talk about its thing when we get to the digestive system. Well, Suresh, that's one thing. It's going to detoxify you. So yeah, if you're drinking alcohol, yeah, the kidney's got a first shot of turning that alcohol into something that's less toxic, if you will. But yeah, but it also does other important things, Suresh. For instance, I think I've already mentioned this. So here we go. Who do I ask? So what do we call our table sugar? Ashley Yabata. What's the scientific name for table sugar? Okay, nothing from Ashley. Okay, very good, Ashley. Outstanding. Joshua, okay. And let's make sure we got this. All right, so sucrose is what it is. All right. And so who do I pick on? I'm going to start picking on people that are kind of like hiding in the corners there. That I haven't heard from. Nada. What is sucrose? It's a disaccharide. It's made up of two other monosaccharides, two other sugars. One is, and you fill in the blank, one is, what is sucrose made up of? What are the two simple sugars? Nada, you there? Okay, Andy, very good. Glucose and fructose. Glucose and okay, great. I like all the responses. I love to see the responses. All right, so glucose and fructose. All right, and I'm pretty sure I talked about this when we talked about the endocrine system. Your body cells can only use glucose. So when you take sucrose and you break it into glucose and fructose, your body cells will use the glucose. Can anybody remember what I said? I don't blame you if you don't. It was kind of not a big deal. The fructose is going to go straight to your liver. Can anybody remember what your liver is going to do with that fructose? No. Bucola had half it in there. Bucola was onto something. Okay, all right. So yeah, Andy, it's going to initially make it into what? It's the other G word. It's going to take fructose and make what in the liver? What do we have lots of in the liver? Very good, Bucola. Very good, Christine. Very good, Suresh. Very good, Christina. Yes. We're going to make glycogen, which is the storage form of glucose. So yeah, because your body cells can't use fructose as an energy source. So when you eat your table sugar, half of it's going to go to your cells, the glucose part, and half of that sucrose is fructose that will go to your liver, which will ultimately change it into glycogen. And there you go. So that's just an example of this hepatic portal system. All right. And yes, as somebody said, it's also going to detox the things that you ingested, whether it was drugs, legal or not legal. I shouldn't say that, but anyway, whatever. And like I said, you could take 2 semesters on just the liver physiology. It's pretty freaking amazing. All right, let's move on. All right, so here is all the anatomy that I'm going to fly through just so you can hear me pronounce the terms. But again, this is all stuff, because I used to hate that. I'd be bored. You can sit there and just talk to a slide. So I'm going to fly through this to make sure you can spell them, or not spell them, pronounce them properly. Okay, so we already know about the aorta, and then the aorta is going to have some major branches. All right. So the big one is the brachiocephalic. Brachiocephalic. And think about that. So that brachiocephalic, and it says trunk. Everybody see the word trunk? And I mentioned this earlier, but a trunk means it's going to branch. So brachiocephalic. So where are the 2 places it's going to go? Somebody impressed me by just that term, brachiocephalic. That's going to branch into 2 other arteries. And where are they going to go? Come on, guys. This is way back one in your AMP1 class. What does brachio refer to? Somebody. Thank you, Suresh. Yeah, your arm. And cephalic? Not necessarily the neck. What does cephalic refer to? The head. Very good, Jennifer. The head. So yeah, and of course we'll talk about these arteries in a little bit more detail, but yes, we're going to go to the carotid arteries, and those are your major arteries that feed your brain, and subclavian. And again, break these words down so they're not just, they're not foreign. What does subclavian mean? Somebody, anybody. I'm going to start picking.
It sounds like it's beneath the clavicle.
You just nailed that. Excellent, excellent. It's behind the clavicle. All right, so it's an artery. It's going to be right behind your clavicle as it goes down to your arm. Excellent. Good job. Excellent, excellent, excellent. All right, sub below clavicle. All right, beautiful. Like I said, the key to anatomy is trying to break it down. Then you have, like I said, the aorta. We say the aortic arch because it comes around. We feed the brachiocephalix and the carotid, and then we go straight down until we get into our thoracic cavity. So again, it gets a minor name change, and you're going to see this a lot. It's kind of funny to me. But every time an artery passes through another region of the body that you learned about, it gets a simple name change. All right, so we have the thoracic aorta for the lung area, and then the abdominal area that's going to feed our digestive system. All right, beautiful. Beautiful. All right. We've already mentioned the vena cava, so that's, again, bringing blood back to the right atria. And again, superiors from the, drain the blood from the head and the arms and whatnot, and the inferior vena cava from the lower half. Simple, simple, beautiful. Here is, again, presented for your lab knowledge. So these are all the things that you need to know for your lab practical. And again, a lot of them are very simple. They basically are named after what organ they're feeding or what part of the body they're passing through. So we'll go through these rather quickly just so I can pronounce them for you. So we have, excuse me, off the brachiocephalic trunk, two major branches, boom, boom. One's going to the head. And it's going to branch into what we call the internal and external carotid arteries. The internal is going to feed your brain. It's going to go straight up to that cerebral arterial circle. The external is going to feed all the arteries that make up your cranium and your face here. And then the itty bitty one that we don't care about is the vertebral artery. All right. So you're going to see this a lot, folks. So pay attention. When you see common carotid, you know that's going to branch into an external and internal. You're going to see that a couple more places. Okay. And then, of course, the brachiocephalic is going to also branch off into the subclavian artery, and that's going to go down your arms. All right. Don't worry about the internal thoracic artery. You guys hopefully are taking notes like in the good old days. So don't worry about the internal thoracic artery. It's not a big deal. Or don't worry about that. Okay, so this is what I was talking about. So let's look at this brachiocephalic. It branches to my subclavian, and blood's flowing. And when it gets to the armpit or axillary area region, it just gets a name change to axillary artery. For just a short time, then it's going to go down your arm, and boom, it gets another name change to the brachial artery for your arm. And surprise, surprise, if you remember anything from AMP1, it's going to branch out to your radial and ulnar arteries, named after the two bones that flow there. Very simple. Very simple. All right. And then, of course, that's all you need to know about that. If you were a vascular surgeon, you'd have to know more branches, but this is as far as we go. All right. And then we get into the abdominal aorta, and then there's a lot of branching because that's where all our organs are. And once again, a lot of them are named after the organ they supply. So we simply have the renal arteries, right and left, that feed the kidneys. We have a trunk. Remember what I said, a trunk means it's going to branch off and it's going to go all kinds of ways. So one branch off the celiac, it's called celiac. Everybody say that to themselves, celiac. All right. And that's going to branch and go in different places, as we're going to see in just a little bit here. So you have the celiac trunk, and that's going to go to your digestive system, your spleen, your stomach. Mm-hmm. And then two other arteries that you need to know is the superior mesenteric. Okay. And we'll talk about that mesenteric. And once again, nomenclature. If you have a superior, you must have a inferior. Very good. Very good, Diani. Yeah. So you have a superior mesenteric and inferior mesenteric, and these are going to your lining of your stomach. And we'll talk more about that later. And then at this point down here, our descending aorta is going to have two major branches. And again, it's named for the region of the pelvis. So these are the iliac arteries. So here we have a picture that shows you exactly what that celiac trunk branches out to. One, pay attention with my cursor, one branch is going to go to the liver. So it's simply called the hepatic. Hepatic refers to liver. You guys have all heard of the term hepatitis, that refers to your liver. So hepatic artery is going to the liver. On the other side, the splenic artery is going to go to the spleen, which you'll learn more about when we get to the lymphatic system. And the last branch is called the gastric. And if you didn't know this, gastric refers to what? What does gastric refer to? Yes, Jennifer. Okay, good. Stomach. Good. All right. Excellent. Yeah, I like to hear everybody respond. Trying to get everybody involved. All right. Oops. A little bit too fast there. Okay, I'm looking. And of course, the gonadal artery goes to where? You can use regular talk. Okay, yeah, the gonads. Your ovaries or your testes, depending on what you have. Okay, good. And what did I say? If you have a common iliac artery, if you have a common artery, that means what? Okay, very good, Christine. External and internal. Obviously, Christine is very fast with her typing. Excellent. All right. So let's move on. Oops. We already covered that slide. Any questions on pronunciation? Mesenteric, everyone knows what mesenteric is. So now we go to the lower limbs. And so there's the common iliac, and then you have an external and internal iliac. And here's the tricky thing on your lab practical. So just try to remember this. The internal is really tiny. It's really small. It's right here where my cursor is. The external is large. And as it goes down, it's going to get a name change to the femoral artery. Again, named after the femur. So it's a very, very large artery. And that's dangerous because I like to watch, I'm military, so I like to watch lots of war movies. And if you get shot and you pierce the femoral artery, what's probably going to happen? Somebody. Okay, very good. All right. I'll put these together. I love your answers, guys. That's good. Bleed out, blood everywhere, bleed out, death. Yeah. Okay. So Rich goes with high field volumetric shock. Yeah. But in simple terms, yeah, your chances of surviving that are pretty low. What's the desperate attempt you're going to do? All right. Yeah. I was going to see who could spell tourniquet correctly. those darn French words. Right. So yeah. So yeah, you're going to try to put a tourniquet on there. I don't know if you guys understood. You know, I make some assumptions that even everybody knows what a tourniquet is. Does everybody know what a tourniquet is? I don't want to insult everybody, but yeah. All right. Okay, good. And no kidding, if Christine worked with Stop the Bleed. So if you see somebody that's bleeding out from the femoral artery, what are you going to use that is super handy to create a tourniquet? In fact, it's very good. Very good, Natalia. Very good. Yeah, a belt. Because you want to put a tourniquet on somebody to shut off the blood so they don't bleed out. But you need to loosen it once in a while to get blood flow to that area to some degree. So yeah, a belt is the best thing to use. All right, that's your practical bit for the day. All right, and then we have the veins. And again, they follow the same rules. Most of them are named after the parts of the body they feed or the regions of the body that they flow through. All right, so pay attention here because there's things in here you don't need to know. All right, you need to know the superior sagittal sinus that goes right in between the two right and left cerebral hemispheres. All right, and remember, sinus just means a really, really large vein. All right, and then you have the inferior. Boom. And now this branches, and then there's things you don't need to know really because we don't have any way to present them in the lab exams. We don't have any pictures. So you don't have to worry about the transverse sinuses. Again, they're going to branch into right and left, and you don't have to worry about the sigmoid. Somebody tell me what sigmoid refers to. What do we mean by when we say sigmoid? Because you'll see that in other places. Anyone know what sigmoid refers to in science in general? No one? Okay, sigmoid just means S-shaped. S-shaped. All right. So you see how there's a little bend, a couple bends. So sigmoid just means S, and you'll see that in other parts of anatomy in this course. So you don't really you don't need to know those two, but they will form to what's called a jugular, and I'd like to think everybody knows or has heard the term jugular vein. All right. So again, you have to know the superior and inferior sagittal sinus. You do not need to know the transverse or sigmoid sinus. You definitely need to know. Don't worry about the foramen. That just means you should have gotten that in AMP1. That just means the hole that the jugular passes through. But you do need to know the jugular veins. All right. So again, listen to me carefully. You don't need to know any of the facial veins. So don't study the ophthalmic or the temporal or facial or occipital or posterior auricular. You just have to get to the jugulars. Does everybody hear me? You're not responsible for those first 5 on the slide. Okay. Now, this is where students always get confused. We have an internal and an external jugular vein, okay? There's no common, and some of you are going to get that confused. You have a common carotid on the arteries, because it branches. But the veins aren't branching, they're coming together. So there's no common jugular vein. The internal and external go straight to the brachiocephalic vein. Again, you do not need to know about the vertebral vein or the thyroid veins. I'm not going to ask you that. All right? So the main internal and external jugulars are going to feed right into the brachiocephalic vein. And again, there's that word, brachiocephalic. So they're going to get blood from the subclavian vein, just like we have in the artery. And again, we have the same kind of thing, although it gets kind of weird with the veins. I never understood that when I was in school. So we have the right subclavian vein. Okay, that makes sense. The axillary vein. And then it gets kind of weird. We have the brachial vein. I mean, but what the heck? There's a cephalic vein? I don't understand that for the life of me. What did I say? What does cephalic refer to? Yeah, so that's just one of those weird things. I was like, what? That doesn't make any sense. But it is what it is, all right? And then you have another vein called the basilic vein. And then we have our median cubital vein. This is a very important vein. This is a super important vein for a lot of you people. Why? Exactly, that's where you're going to draw blood from. Very good, excellent. All right. So those are all good. Don't worry about, in fact, you can blow off this entire slide. You do not need to know the azygos veins or hemiazygos. I'm not going to ask you anything about costal veins. All right, so just ignore this slide for the most part. Okay, beautiful. And like I said, we have the ulnar and radial and the median cubital. That's what you need to know. Don't worry about the basilic. I'm never going to ask you about the basilic vein. All right. And there's your GWAS. Yeah, that's what you're looking for. If every patient looked like that, right? All right. Oh yeah. The more exercise, the leaner you are, the easier it is to find that thing. Okay, let's get to the abdomen. Again, most of the stuff is just named after the parts of the body they go to. So hepatics going to the liver, or coming from the liver. Let's get that straight. All right. And again, looking, okay, there's nothing in here that I need to pronounce for you, so you guys can just study that. Don't worry about the ascending lumbar vein. I'm not going to ask you that. Remember what suprarenal means. Supra is above, renal, kidney. So here's your GWAS. What are those veins draining blood from? What do we call this right here? What is that? Somebody. Okay. Excellent. Okay, good job. Okay, beautiful. And there's the hepatic portal vein that we talked about. So remember, this is going to take blood from the digestive system, the stomach and the small intestines, and it's going to go straight to the liver, so the liver can process it. All right? Okay, and looking, looks like everything else looks pretty straightforward. And again, we're following the same strategy as we did with arteries. So you have a common iliac and an internal and external iliac. The only thing very different here, pay attention to what I'm saying, is you have the femoral vein, but then you have another fairly large vein called the great saphenous vein. Oops, I didn't mean to do that. All right. And so that's the vein you can probably see on your inner thigh. Okay. The femoral is a little bit deeper. So don't get these two confused. A lot of students do that on a lab practical. How would you describe the location of the great saphenous vein versus the femoral vein? You could say superficial versus deep, or how else could you say that? Somebody from A&P1. The great saphenous is more what? No, it's not higher or lower. Very good, Ashley. Very good, Christina. Yeah, it's medial, towards the middle. Very good. It's superficial, and you can say it's medial. All right, good. And then remember, popliteal means at the knee, behind the knee specifically. And then again, after the bones, vestibular and tibial. And that's it. Any questions? All right. Okay. So let's take a 10-minute break. And we'll go on with the actual physiology. So be back at 6:45. Let's make it a 15-minute break. So be back at 6:50. Everybody got that? 6:50. And we're not going to change rooms because I'm not taping anything. So we'll just continue on with this. All right. I'll see you in a little bit. How we doing? Now the fun begins. Now we get into the physiology. So I'm excited. Yay, very good. Christina has the right attitude. And not to scare anybody, but there is some math here, but we're going to keep it as simple as I possibly can. So Deanna's drinking coffee at 6:30, 6:50. I remember those days. Those days are over. I can't drink coffee at 6:50 at night. I'd be a wreck. But I do miss the good old days. All right. Christine made chicken tenders. Okay. Yeah, I kind of gulped down a couple of old barbecue ribs from Rudy's. So, life of a bachelor, I just eat whatever I can scrounge around. It's like, the biggest conspiracy in the world is, anyone? When it comes to your refrigerator, and this is for your micro folks. Nobody? No, that's the truth. No. To me, the conspiracy is expiration dates. All right? I don't believe in expiration dates. You know when something in your refrigerator is expired? There you go. That's better. That's better. Yeah, you guys all nailed it. You know it's expired. Okay, Andy, you're onto something. Yeah, but no. You got to remember, I was in the military for 25 years, and I went to all kinds of survival schools. So, in the military, there's no such thing as a 5-second rule when it hits the ground. It's more like a 5-day rule. But yeah, nothing's expired until you see something actually growing on it or you smell it. Thank you, Deani, for confirming that. So like I said, I have some things in that refrigerator that's been in there for 3 or 4 years. All right, looks like we got, well, I was kind of stalling because we only have 17, but this is the technical stuff. But yeah, so looks like you guys all agree. Yeah, it's like, yeah. So you smell it? And I have 4 dogs. I don't know if I told you that. So I let them smell it and see if they'll eat it. Then that's okay. All right. We'll go ahead and go. We lost about 4 or 5 people. All right, so this is the physiology, and this is a little bit complex because we have a little bit of what you want to call fluid dynamics and whatnot, and just a tiny bit of math, All right, so when we talk about the physiology, we're talking about blood volume, blood flow, blood pressure. And we're going to look at all the mechanisms that deal with flow. But who can tell me what the relationship is between volume and pressure? Inverse. Christine eloquently said that with one word. Yeah, so normally, and we'll talk more about this when we get to the respiratory system, yeah, volume and pressure are inversely related. And so that's a huge concept in this, because this has everything to do with what you guys are going to be dealing with in your futures, because once again, one of the biggest problems in this country is high blood pressure. High blood pressure. All right? So I'm gonna take it to the next step. So if I have a person with high blood pressure, what am I going to do to try to fix that? All right, well, you just jumped way ahead. Okay, you guys are way ahead. So, yeah. Yeah, of course, Josh, we want to decrease it. But you guys are a little bit too deep in the... It has to do with what this slide says. Look at my slide. So if I have high pressure, what do I want to do? Well, I want to lower it. How am I going to lower it? You dilate the vessels. Very good. If I increase the volume, which is synonymous when we're talking about the circulatory system, if I dilate my blood vessels, I increase the volume, which should decrease the pressure. All right? So yes, those are the answers I was looking higher the volume. And what we mean by higher the volume in the circulatory system, that means vasodilation. Vasodilation. And that's what this is all about. All your high blood pressure medicines are all about vasodilation to begin with. And then, of course, like somebody said, very good, beta blockers. We've already talked about that. Great. All right. So let's press on. So we have our relationships of pressure, flow, resistance to flow. And then most of this lecture is going to be on controlling those relationships with all the mechanisms that we have available. All right. Now, here I want to say something so it makes sense to you. So when we talk about vasoconstriction and vasodilation, vasoconstriction is all about contracting the smooth muscle in the blood vessel to reduce the lumen, the size. That makes sense. This is active. I am going to excite this smooth muscle and get it to contract to cause vasoconstriction. Now, pay attention. Vasodilation is passive in a sense, is we are going to inhibit the smooth muscle so it can't contract. And the blood vessel will dilate. Like I said, it's passive. So what's causing the vessel to dilate? I just told you that I'm just going to inhibit the smooth muscle, and it's going to automatically dilate. Why? No. Again, this is... Okay, well, that's what we're doing when we dilate, but what's causing the blood vessel to physically dilate? I've inhibited, so this has nothing to do with calcium or anything. I've inhibited the smooth muscle so it can't contract. It's really easy. Answer here. No one wants to take a guess? No. Let's not get away with the sympathetic parasympathetic. I'm just asking you, if I inhibit the smooth muscle so it can't contract and it dilates, why did it get larger? No one? I'm not even sure what that means, Amy. Constriction. Smooth muscle, that I don't know where you're going with that. The smooth muscle is inhibited. So what physical thing is happening to make the blood vessel dilate? No. You guys are, okay, yes, it's relaxed. And yes, it's vasodilating. What's causing it to vasodilate? What's causing it to expand? I'll give you a hint. It's on the slide. All right, Christina. Pressure. Yeah, blood pressure. Not flow, pressure. Blood pressure, the smooth muscle is relaxed, so the blood pressure is going to make the blood vessel dilate. So again, vasodilation is actually inhibiting the smooth muscle. The smooth muscle is relaxed, as somebody put, and so now the pressure of the blood is going to make it expand. I just want you to get that so you understand that when you cause vasodilation, you're actually inhibiting the smooth muscle. All right. So here we go. Blood flow. And again, very simple. Blood flow is equivalent to cardiac output. Somebody tell me what cardiac output is. Come on.
Stroke volume.
Well, that's half of it, I guess. What is cardiac output? Very good. And that would be what? Very good, Jennifer. And that would be what? What would be the normal cardiac output? What is it? Come on, what's the average cardiac output that you learned last unit? Okay, Samantha goes with a hardcore 4,900. Good. Christina rounds it up to 5,000. Somebody goes with 4.9 liters. All right, great. All good answers. So yeah, very good. All right, here's a cool slide. This isn't what, you don't have to study this. There's nothing on the test for this. It's just a very cool slide that emphasizes what I've been talking about for quite a while. Check this out. All right, so let's go with the bottom. Here's at rest. There's my 5 liters per minute, as you see, for cardiac output on the bottom. And so now we're under the parasympathetic, rest and digest, and look where the blood is going. 20 to 35% to my viscera, my intestines. 20% is going to the kidneys. 4 to 5% to the skin. Now I'm exercising. And this is a pretty hardcore exercising person at 25 liters per minute. That would be an elite athlete. But look what happened. Where's all the blood going? Look at that. Yeah, skeletal muscle. Dramatic shift. And that is because I vasoconstricted to my viscera and skin and sent it all vasodilation to the skeletal muscles. So that's just again, I just want you to appreciate the dramatic shift of where your blood is going when you're exercising. All right. Okay. Very cool. So let's press on. Yeah, it is very cool. Okay, we already know blood pressure. I already explained where we get the term millimeters of mercury, right? From our barometer. And again, blood goes, and I want to emphasize that, if I didn't emphasize that enough in the cardiac lecture, your heart isn't like a water pump, all right? It's pushing blood out and then bringing blood back in. The heart is basically just pushing blood out. And then it's going to get an assist from things like gravity and your skeletal muscles to get it back to the heart. We talked a little bit about venous return when we talk about cardiac, but now we're going to go into greater detail. All right. So here's a tiny little bit of math. Don't let it freak you out. All right. So this is something you want to study. Blood flow is directly proportional to the difference in blood pressure. All right. So we're talking about from going from point A to point B. So if we look up here, on our first little vessel here, it shows 90 high, 10 low, and that's basically what we have in our circulatory system. Your blood pressure is about 90 coming out of the aorta on average. Our blood pressure is 80, 120 over 80. The average is 90. I'll explain that in a little bit. And then when it gets to your vena cava, it's 10. So my delta P is 80. Everybody see that delta P? You need to know that. Delta P from your aorta to your vena cava is 80. It's going from high to low. It's the same thing as diffusion. Instead of we're talking about pressure versus solutes. So high pressure to low pressure. And you need to know that concept when we get to the respiratory system as well. Okay? So it's inversely proportional. So if my delta P is high, the difference between point A and point B, I have high flow. If I have a low pressure difference, then my flow is going to be low. Very simple. And of course, this is bad. No flow. And remember, it's all relative. And we talked about this in cardiac. So I need this 80, delta P of 80 millimeters to get nice flow. But here's our patient down here that needs to still have that 80 to survive, to live. But now I have 180 and 100. This is bad, as we talked about with your heart. That's going to put a lot more stress on your heart. Okay. So, again, we have this. Would a patient 2 be someone with it could be a lot of things. A nuclear test. Oh my gosh, we could spend hours talking about what causes. We'll cover the basics in this course, but again, there's a lot of things that cause high blood pressure. A lot of things. We talked about some in cardiac. We're going to talk about more here. All right. If you remember your cardiac, so just hold that thought there, Joshua, and we'll talk more about that in a little bit here. Okay, so again, we have our pressures, our systolic and diastolic, but eventually that what we call pulse pressure, the difference between 180 or systolic and diastolic, eventually when you get down to your arterioles and capillaries, there's no pulse anymore. And hopefully, well, you may not know that, but there are no pulses in your veins. The only pulse you can feel or manipulate or palpate, is the actual correct word, is the arteries. Right? So we have this 120 over 80, ventricular contraction, relaxation. When we get down to the capillaries and arterioles, we have no more pulse. All right? Beautiful. All right, so a little bit more basic stuff here. It's a tiny bit of math. So you need to know this simple equation. Flow, F, is equal to delta P from high to low over R, which is resistance. That's it in a nutshell. All right? So, a little bit more math. Resistance, which is, your blood going through your blood vessels, and so there's friction and distance, and that's going to cause a little drag, if you will, on the flow. As the resistance goes up, the flow goes down. So we call this inversely proportional. All right. So when we go back here and we're talking about blood flow, this R is way more important in your body than delta P. Your delta P is going to be relatively consistent most of the time. What can change dramatically is the resistance to flow. Resistance to flow. So what causes resistance? Viscosity. How thick is your fluid? Your viscosity. All right. What's a good analogy to viscosity in terms of thickness would be, okay, here's a little childhood anecdote. When I was a kid and we behaved, my dad would take me and my three brothers to McDonald's. And we would get a McDonald's milkshake. Yeah, which is very rare, Andy, yeah. Can you imagine 4 boys in the house and we were all freaking they didn't have that term back then. I'm pretty sure we were all ADHD back then, but anyway. So you go to McDonald's, of course this is way back when, and you get that milkshake, and what was the most frustrating thing about a McDonald's milkshake with a paper straw? Yeah, it was stupid, you know? Yeah, exactly. You're sitting there, and like I said, this is before we had plastic straws. So way back when I was a kid, you had a paper straw, so that would collapse because you couldn't get the damn milkshake through the straw because it had too much viscosity. It was too thick. All right, the struggle. It was like what? 25 years later, they came up with a thicker, wider plastic straw with a spoon on the end. I was like, yeah, where was that when I was a kid? Anyway, so that's viscosity, all right? And so the factors there is your blood can have different viscosities depending on what we call hematocrit. You're going to learn way more about hematocrit on Monday, but basically for the now, hematocrit is how much of your blood is actually red blood cells versus plasma. So the more red blood cells you have versus plasma, which is mostly water, the thicker your blood's going to be. But for us right now, we're going to say that that's constant. Your hematocrit, the number of red blood cells you have per ratio to plasma, is about constant. The other thing is length. How long is a blood vessel? The longer any vessel or any tube is, the more resistance they're going to be. And I'll give you one more anecdote. When I was a little kid, we used to watch those 1950s sci-fi movies. And one that I remember vividly was something about the monsters on the bottom of the ocean. And then there was this guy in a bell helmet in the bottom of the ocean, and he had a tube from the ship going down there so he could breathe. And we're like, that's cool. Let's try that in the pool. So we got the garden hose and jumped to the bottom of the pool and tried to breathe through the garden hose. How well do you think that worked? Exactly. No, you can't do that. Your lungs cannot breathe through a garden hose. It's impossible. It's too long. And anyway, so the point is, for us today, even though the viscosity and length are resistance factors in our body, we're an adult. So in math, If you have something that's constant, that doesn't change, we can substitute 1, the number 1. 1 times anything is just anything. So the only thing that we are really truly concerned about is radius. And we're talking about vasoconstriction and vasodilation. All right, so here's the math, and I don't want you to freak out on this. All right, so our formula for resistance is 1 that incorporates viscosity and length, but we said they're constant, they're not going to change it, so we can just use a 1. And then under here, which I'm not going to try to explain, since I don't think any of you have had college physics, maybe some have had, but our resistance is basically the radius to the 4th power. All right, so I'm going to go to my camera here and go over a little bit of math. And again, do not freak out. I'm going to keep it simple for you. Okay. I've got wires everywhere. All right. Everybody see this? Are you good? All right. So again, resistance, big R, is equal to 1 over radius to the 4th power. All right. Let me find my marker here. So you will have one problem on your test to calculate resistance. And we're going to keep it super simple. All right? So let's say we have a blood vessel. All right? Okay, and we're going to say it's the radius, which again is from the center to the periphery. Radius, small r, is equal to 1. We'll say centimeter, whatever. Everybody with me so far? Okay. Now we're going to have vasoconstriction. We're going to make the blood vessel smaller. So the radius is now 0.5 centimeters. Okay. Now you're going to calculate resistance. You're going to say, follow me as we go through this. So I have my formula. R is equal to 1 over my radius is now 0.5. So I'm going to put 0.5 in there to the 4th power. All right. I hope somebody has their calculator. What is this? What is 0.5 to the 4th power? Wow, Christina, Joshua, impressive. Very good. So I hope everybody's following and not let Christina and Joshua get away from you. So 0.625. All right. Okay, Samantha. And so you guys are way ahead, which is equal to this divided by 1 is 16. So when I decreased my radius from 1 centimeter to 0.5, the resistance went up 16 times. 16 times. That's tremendous. All right. For instance, if my blood flow was 400 milliliters per minute here, and I had vasoconstriction, and now my resistance is 16 times, my blood flow is now what? Exactly. That is a considerable difference. So my blood flow was 400 milliliters per minute at 1 centimeter. I had a vasoconstriction to 0.5. I went from 400 to 25 milliliters. Now this is dramatic because none of your arteries actually are reduced by half. But these are the easiest numbers I could come up with. So I'm going to give you something very similar to this. Oh shoot, I'll tell you what. I'm going to record this little part for some of you that you go over it one more time. So there's my formula. I started out with a blood vessel that had a 1 centimeter radius. I vasoconstricted it to 0.5 or half. I took that 0.5, put it into my formula, came up with this. That's my increase in resistance. And whatever I gave you or give you here, you're just going to divide it by the 16, which was, again, the increase in resistance, and you're going to give me the number. So I'm not going to give you this exact one. I'll keep this so as not to stress you, but I might just change the blood flow. Instead of 400, I may say 600. Everybody got that? Your delta looks, okay, there's no delta here. All right, this is blood flow. This is the amount of blood that's flowing through my particular artery at any given time. All right. Oh, Katie joined us. Great. All right. So this is the flow of blood. I constricted the artery, reduced the blood flow significantly. Any questions with that? All right. If I went too fast, then you need to look up Katie, and she can go through this. She's seen this a million times. All right. Yes, as Katie said, and I can do the exact opposite. So I could say it would start at 1 and make this 2, and it would be. Do I need to go through that? Okay, no, yeah. So, yeah, like Katie said. So you would, instead of, real quick, something like this will be on the test, all right? Okay. So I do need to go over it, is that what you're saying? All right, so let's say that I had vasodilation. Well, it's bigger. I'm going to keep that. My radius is now 2 centimeters. So I go back to my formula. R is equal to 1 over 2 to the 4th power. And that's going to give me what? $16. So now my resistance has been reduced, or it's 16 times less. So then you take 16 and multiply it by the 400, and you would get a ridiculous number because we're using ridiculous things. There's the only artery you have in your body that's 2 centimeters is your aorta. But so then you would just go 16 times 400, and you would get 6,400, which again is ridiculous because that's obviously higher than your whole cardiac output of 5,000. But I'm trying to keep the math real simple for you here. All right? But your question in your test will be about vasoconstriction, not the vasodilation. All right? Okay, let's move on. And that's all this slide was saying. Everything I just wrote down. All right? All right, don't let this slide scare you. I'm not going to make a big deal out of it. We can put this in terms that you understand every day. It's just saying that the speed, we're talking about velocity, how fast is the blood flowing, is based on the area, cross-sectional area, how wide this is. So the larger the cross-sectional area is, the slower the blood flow, and vice versa. If I go from high cross-sectional area, where it's nice and slow, and I reduce it, the flow would be faster. Who can think of an example of this in everyday life? Hint, hint, you're watering your lawn. Unless you've never watered a lawn before. How do I make the water go faster and farther with my hose? No, bending would just slow it down. But somebody got it. Joshua, yeah, you put your thumb over a part of it. You reduce the cross-sectional area. Now the flow is faster, so it'll go farther out. I'm sorry, some of you have never had to water a lawn, I guess, old school ways. Okay, Katie's joined us with her humor. All right. All right, but here's another one that maybe more people are familiar with if you haven't watered a lawn. Somebody impressed me. What about if you're tubing down the river here? What do you notice as the river gets wider and narrower? The tubes start getting stuck. Oh my God. What do you mean, Daniel and Christina, it slows? It slows when? Okay, you're going to stick with that, aren't you, Andrea? Very good. That's what I wanted you to get. Yeah, as the river gets wider, things slow down. As the river gets narrower, it speeds up. Exactly. Same concept. Absolutely same concept. All right? Because it's, again, increased cross-sectional area. Okay, but you don't have to know any of this math, so don't worry about that. What counts is this slide. So, basically, okay, so how this applies is because we don't have any blood vessels. Let me go back here. We don't have any blood vessels that go from small diameter to large diameter. This isn't a thing. But we have the equivalent because, again, we start with the aorta, and it branches, and it branches, and it keeps branches till we're down to the capillary level. And you need to think of like, okay, I started with the aorta, which may be 2 centimeters in diameter, and then it branches, and now we have literally hundreds of thousands of capillaries. Each have their own diameter. They're much smaller, but you add them all together. You add all the capillary cross-sectional areas together, and you get this huge difference. The cross-sectional area of the aorta, maybe 2, and the cross-sectional area, if you had all the little capillary diameters together, you'd have a cross-sectional area of 5,000 square centimeters. And so, if you look down here in the bottom, blood coming out of your aorta is flying, all right? We're talking like 30 centimeters per second. Think about that, 30 centimeters per second, all right? By the time it branches and branches and gets to your capillary, it has slowed down to 1 or 2 centimeters per second. And again, it has everything to do between the capillaries being small so that our red blood cells go single file, but now they're slow, so I have plenty of time to unload the oxygen and the nutrients to the tissues. That makes sense to everybody? Beautiful. Good, good, good. All right. So we will press on. Okay, folks. When we first started this lecture, I mentioned one of your big essay questions is going to be compare and contrast a vein and an artery form following function. So this is one of your big study slides. There's a couple more to add to this, so we need to identify them. So I'm not going to go through all of this. I'm just going to go over some of these things, but I want you to put together. So this is the closest thing I have to homework, if you will. So for instance, form following function, arteries have thicker walls and narrow lumens. They're thicker because they have to withstand the high blood pressure. But the same token, I want the narrow lumens to maintain that high pressure, just like our hose, water hose. All right. I mentioned earlier about our elastic arteries. They have to be elastic. So once the left ventricle pumps it into the aorta expands, as I said before, and then it recoils and shoots the blood forward. All right. This is a very important concept here. It has everything to do with your heart. That's why I emphasize this. All right. Now, what's the simple term for atherosclerosis? Anybody? Atherosclerosis, arteriosclerosis. What's the simple term? Nobody knows? Well, it contributes to heart disease. So no one knows what atherosclerosis is all about. Okay, plaque in the arteries. So what do we call that in general terms? No one's heard of the term hardening of the arteries? Yeah. Okay, yeah. So hardening of the arteries means just that. We've lost the elasticity. And if I don't have that elasticity, then when the left ventricle pumps that blood out, it doesn't get that expansion of the aorta and then the recoil to help propel it forward. And so the heart has to work harder. So all these contribute to high blood pressure, as we said. So now our arteries are thickening through plaque and the loss of elasticity. So I don't get this jet-propelled, flow of blood. And so the heart's going, geez, now I'm working harder. Now I'm going to just freaking quit. Okay? All right. So I'm trying to give you why we're talking about this. All right? Veins have large lumens and thinner walls. We want them to be compliant, meaning we want them to be able to nice and stretch and hold all the blood in there. Most of your blood is on the venous side. So compliance just means the ability to stretch and give, if you will. All right? And they have larger lumens, which is related to our, let me go back here. Oops, that's too far. Oh, yeah, here we go. So remember, resistance, right, is all about the radius. So if I have a large radius, I have lower resistance because the blood pressure is really low on the venous side. It's down to 10 to 20 versus 80 to 120. So I have very low delta P, if you will. So I need to reduce my resistance. I do that by having large lumens. Okay? Anyway, so this is one of your study slides, and here's just a little visual thing. And again, on your test, it's all about the artery and the vein. I don't want to hear nothing about about capillaries. What are the two things that you're not going to put on this answer? Two things. Well, at least tell me one thing, but two things. When I ask you form follows function, what aren't you going to put on this? I want you to think hard. What is not something I want to hear? Yeah, stupid Calvin. Come on. When you answer this question, what are you not to put on this when you compare an artery and a vein? Okay, that's right. Joshua, squishy versus round, that's not a thing. That's a histological. Come on. What are the two differences between arteries and veins but has nothing to do with their structure?
That's a legit answer. Squishy versus.
Exactly, Andrea. That's exactly. I do not want to hear that. And Katie, yeah, I explained to them on the histological side why the vein was squishy, but Andrea just nailed it. All right, I don't want to hear about blood going from or to the heart. That's not a structural difference. That so that's part of it. What's the other one? That's warm. What else aren't you going to say?
Oxygenated.
Yeah. Okay. Who just Katie?
I'm sorry. Oxygenated.
Yeah, okay, Andy, very good. Yeah, I don't want to hear about nothing about oxygenated versus deoxygenated. Again, it's not a form and function thing, all right? So those are the two things. Direction of blood and oxygenated versus I don't want to hear about that. Okay, I hope I made that clear. I hope everybody's paying attention and they wrote that down, because you get no credit for that. No credit for that. All right, here we go. All right. And I've already talked about this. So this is kind of just re-emphasizing so you guys do not get this stuff confused. The elastic arteries expand and recoil, and this is it. That's it. Just propels the blood forward. It's the same thing as if you were to fill up a water balloon and then let the neck go, and the blood would just, spurt out because of the pressure and the elasticity of the balloon. All right? Beautiful. The muscular arteries are all about constricting and directing blood to different areas. And again, arterioles, this is where we start distributing the blood. And so we have we're pretty much don't have a pulse of any kind at this point. The pressure drops, and it's just where are we sending the blood? All right. We've already talked about this. I should not talk about that anymore. You already know. I explained this. So here we go. This is what you do in lab, and we can do this on Monday. If we were in lab, it would be very simple. It would be like a 20-minute lab thing where you would actually take each other's blood pressure. Jeez. How many of you do this now in your jobs? Who takes blood pressure? Amy? Christina has her own. Well, that's good. All right. So only Gabriella actually does this for a part of her job? Christina, what do you mean you have your own machine, but... that's pretty clever. I've never done that. All right. So I want to make sure you understand exactly what you're doing if you do blood pressure the old-fashioned way, which is by far more accurate than one of the little electronic ones that you can get at CVS or Walgreens. I have one, but I usually take my blood pressure like 6 times and then get an average because it's all over the place as far as the machine. But I want you to understand exactly what you're doing, not only for the test, but in your future careers. Because you can certainly embarrass me in nursing school or dental hygiene or whatever if you say something really, really dumb. And I'll explain what I mean by dumb in a second. So what happens when you take blood pressure? Well, you're going to put a cuff. Yeah. It's sphygmomanometer is a little old school, but it's by far more accurate than the digital ones. And that's because I'm old school. What's wrong with a digital one? I know you guys aren't all scientists, but what's the problem with using a digital one? Okay, that's one thing. But it's from a scientific standpoint, what can't you do with the electronic one that you buy or use? I'm not going to drag this out. You can't calibrate. Who said that? Who just said that? Dang. Great job, Andrea. I'm super impressed. All right? You can't calibrate it. All right? So old school. But even with the new ones, this is what you're doing. Yeah, gold star for sure for calibration. All right. So pay attention because this will be on your test, and I want you to make sure when you go into your programs, God, especially if you tell them, everybody in the nursing program knows who I am. So so please don't embarrass me. All right. So, and I'll explain what I mean by that. So you're going to put a cuff on your brachial artery. That's what we're working with. And we're going to put enough pressure in that cuff to squeeze off that brachial artery so there's no blood flow. It's quiet. All right. We've done our job. And so how much pressure and we're going to pump it up with our little squeezy thingy here down here, old school way. All right. So we're going to fill this up and we're going to look at our pressure. And somebody said that we have a couple people that used to do that or still do it. How much pressure are you going to put in there? And that's a perfect answer, to be sure. Yeah, because you can kind of tell. It's an art. It's an art. If you have somebody like, oh boy, this is going to be bad. So for those of you that don't know exactly what we're talking about here, is we have to put enough pressure in that cuff to shut off blood flow. If they have high pressure, blood pressure, you're going to have to put a lot in that cuff. So if it's a normal person, you just have to put it above 120. That will shut off our systolic flow. But if you know for a fact, as Andrea just said, that this person has a history, and I'm going to need to put a lot more pressure to shut that artery down. Everybody follow me. Does everybody understand where Gabriel was talking about? Okay. So I think, on average, you at least put it up to 140, 150 millimeters of mercury pressure, shut the flow off. And this is where taking blood pressure is a skill. It takes practice. It's an art form. All right, and you're multitasking. You got to do a couple different things at the same time. So you're going to fill this cuff with enough pressure to shut the flow off. You're going to be monitoring that gauge, see where it's going, and then you're going to slowly release the pressure. Now, as the pressure decreases in the cuff, you're going to be listening. And there's going to be sounds generated. As the blood flow squeaks through the artery. The best analogy that I think everybody can relate to is if you blow up a balloon and you take the neck and you stretch it, squeeze it, and let the air out, it's going to make noises, right? Everybody know what I'm talking about? Tell me no one's ever done that before. All right, so as you release the pressure, blood's going to squeak through, just like that air balloon with a squeezed neck, and it's going to make noise. They're called carot cuff sounds. So to take blood pressure, and again, this is with a skill, and the practice comes in, you're going to be listening with a stethoscope, And the first time you hear a sound, the very first time you hear a sound, you look at your gauge, and that is your systolic pressure. That is your systolic pressure. So you're sitting there reducing the pressure in the cuff, and as soon as the blood pressure in the brachial artery overcomes the pressure in the cuff, it squeaks through, makes a sound, and you look at it and you go, aha, there's my systolic. And then you're going to keep listening, and you're going to hear more sounds, and at the same time, you're still reducing the pressure in the cuff. And here's the harder part, is eventually, and if you look down here at the bottom part here, eventually the pressure in the cuff is so low that we have what we call laminar flow, nice and smooth flow, and there's no more sounds. There's no more sounds. And that's the typical part. You have to sit there and go, okay, as you're looking at the gauge, when was the last time I heard the last noise? So it's for your test, the first sound you hear is systolic. The last sound you hear before we get smooth the flow is your diastolic. Everybody get that? I want to hear. I want to see like 20 more. Are you kidding me? Thank you. All right. Now, what did I mean by? Hold on, folks. Sorry, my battery is down to 6%. I couldn't find it. Which one?
Go for it, Andrea.
Okay. So, what I was alluding to, referring to about being dumb.
No. And Andrea has a question.
Andrea, what's your question?
Sorry.
Okay. All right. That's the kind of way I would think. Yeah. Beautiful. Okay. I want everybody to pay attention to what I'm about to say. Okay. Do not say that when you're listening with a stethoscope, you're listening to your heart. Oh my God. You're not listening to lub-dub. You're not listening to anything that has to do with the heart. I mean, think about that. Yeah, think about that. Who in the world would listen to heart valves on their elbow? Okay? And I cannot emphasize, because some of you are probably not paying attention, you're going to put that on your test. You are listening to sounds you created by squeezing the brachial artery. Can I get a yes from everybody? Oh my God. All right. Okay. Anyway, I'll make a big deal out of that. Because again, it just, oh my God, you went to nursing school, PA school, and you're like, oh yeah, I'm listening to lub-dub or ventricular. No, you're not. You made those sounds yourself. All right, I'll get off that topic. And I'm having a technical issue here. Hold on. We're almost done for today. Okay, sorry about that, stupid Mac. Yeah, Andrea, yeah. There should have been 6 more JKs. I hope, sorry for the delay. My charger wasn't working. I had to replace the charger. I think it's an Apple conspiracy. Chargers fail, so you have to buy like 3 chargers. All right. Okay, yeah. So again, everybody promised me on my test and in their future, they will say when you're taking blood pressure, you're not listening to lub-dub or ventricular contractions or pulse. Everybody got it? All right. Sorry to belabor that, but it's one of my little pet peeves. So let's move on. We're going to call it a day here in a little bit and just do a little bit more. So this is just nothing here that you need to worry about. It's just explaining more of the carot cough sounds. But again, on the test, you're going to tell me that when I hear the first sound, that indicates what? Okay, and the last sound? Okay, so there's like a, there we go. That's what I want to see. I want to see everybody typing it in. Beautiful. Stop, Katie. Don't do that, Katie. Oh, because somebody's going to, that's the last thing they heard was Katie say love dub. All right. Okay. All right, let's move on. Okay. A little bit more math. Not, you guys are crazy. A little bit more math. Cindy, you better have put like 4 JKs after you put that in there. All right. Okay, a little bit more math, really simple math. All right, so we can't when we're doing math and flow, we can't use 120 over 80 because that's not a number. So we come up with the average pressure of the 120 over 80. And we call that mean meaning average, not that they're just nasty, just mean. So mean means average arterial pressure, i.e. the average of 120 over 80. And, if you thought about it for a second, like, well, wouldn't that just be 100? 80, 120 average would be, but it's not because, and I'm not going to go into great detail, but your heart contracts for that 1 second there, and it relaxes for 2 seconds. So it's not exactly 120 over 80. And so we come up with this little formula. It's really easy. Your average is the diastolic pressure plus 1/3 of the pulse pressure. And the pulse pressure is the difference between diastolic and systolic. So normally, I just kind of skipped that, is just the difference between 120 and 80 is 40. That's your pulse pressure. All right? So I'm going to go back to my camera and make sure everybody understands what I'm doing, because this will be another question on your test. All right? So let me do the math. All right. Okay. So MAP, mean arterial pressure, is equal to the pulse pressure, 1/3 of that, plus the diastolic pressure. All right, so let's take an average person, 120 over 80. The PP, pulse pressure, is 40. So 1/3 of 40 is equal to 13. Everybody with me so far? All right. And again, it's diastolic plus the third of the pulse pressure. Beautiful. So you're just going to take diastolic, which is 80, and add this, and we get 93. And that's your MAP. That's your average pressure coming out of the aorta. Now, I'm not going to give you this on the test. That's too easy. I may give you something like this, and everybody should try this. Here we go. I have a patient that has a blood pressure, a BP of 160 over 100. MAP equals, do it. Everybody should do it because you're going to get. I like to think that it's quiet because everybody's doing their little math. I made the numbers easy, so it shouldn't take a calculator to do this. So only Joshua, Natalia, and Christine got it? All right, I'm getting no more responses, so again. All right, so for the rest of you that aren't responding, I'll go. So it's my blood pressure. Okay, good. So if I have a person with 160 over 100, the pulse pressure is, again, pulse pressure is 160 minus 100, which is equal to 60. I take 1/3 of 60, and that gives me 20. My diastolic was 100, so 100 plus 20 gives me 120. All right, beautiful. So that'll be on your test. Noted. All right. Okay, I'm good. Good, Deanna, you got it? All right. All right. All right. Okay, good. All right. Okay. Let's see. I'm finding a decent place to end today because we're in great shape as far as time and date. All right, we'll do a little bit more here. It's not hard. And this isn't more of a gee whiz thing. You know, when you're talking about blood pressure, you always have to take gravity into account. All right? Because we have gravity, and our blood has mass and density, so it's affected by gravity. So, depending on where you took the blood pressure would be different. And again, there's nothing on this you have to learn. Just understand. If you took somebody's, who should I pick? If I took somebody's blood pressure sitting down, and then I took somebody's blood pressure standing up, which one would be higher, sitting down or standing up? Anyone?
Yeah, standing up.
Standing up. Yeah. And I want you to understand what's going on there is if you're standing up, your heart, which we learned earlier, says, oh my gosh, the pressure dropped in my carotid arteries. I need to generate more pressure to get it to the brain. And so it would be higher. And the exact opposite. If you took somebody's blood pressure lying down, it would be lower than sitting. Well, Gabriella, that happens, but just for a short second, and see, this is why it all comes together, Gabriella, because again, this goes back to our cardiac thing. If you got up really quickly, and your blood pressure is going to drop for a second, but then those cardiac reflexes come into play, where the baroreceptors in the carotid arteries and the aortic arch and say, whoa, you stood up really fast, the blood pressure dropped because the blood stayed down where you were sitting versus where you are now, but then the heart would speed up and jack up that blood pressure. So that's a perfect example of those cardiac reflexes. And we've all done that. We've all done that, where you stood up really fast, especially if you're nice and chill and relaxed, and then you stood up really fast and you get a little bit dizzy. Have we all not done that? Sure, yeah. That's because you were nice and chill on the sofa, and you stood up really super fast, and all the blood was still on the sofa, and your head was up. Exactly, Christina. Yeah, there's a lot of examples for that. But again, we have the cardiac reflexes that will immediately jack up your blood pressure. Okay, good. So again, this is just kind of a gee whiz thing I wanted you to understand. Because sometimes when you're doing a cardiac test on a patient, you will take their blood pressure sitting down and then standing up to see the differences. That's one of their diagnostic tests they do. All right. And it's time for Rick Fofi's morbid analogy. You know, a great way to torture somebody and eventually kill them? All right, Joshua, you're kind of scaring me. Okay, great sense of humor. But no, Joshua was right on target. No internet, no phone. Oh my God, what could you possibly do with no internet, no phone? Okay, so if you're my age, you do all kinds of crazy things. But I love everybody's sense of humor. Yeah, but no, Joshua nailed it. If you turn somebody upside down, that would be horrible. Because again, and this is all gee whiz stuff, is the blood vessels in your feet are dealing with gravity and pressure, so they're stronger. And so if you turn somebody upside down, hung them upside down, the blood vessels in your brain are not used to that kind of pressure from gravity. So slowly but surely, all the blood would leak out of your capillaries, and that would just be one miserable way to go. But again, and this is what I love about physiology, is the blood vessels in your feet can withstand way more blood pressure because of gravity than the blood vessels in your brain. So if you flip somebody over, bad things would happen. Bad things would happen. And I can go on and on and on about how space travel, that's our problem. Well, yeah, it's medieval stuff for sure, but it works. But that's the big thing. Like I said, I'm an aerospace physiologist. That's our biggest thing. If you're going to travel to Mars and you're going to be in zero gravity for 9 months, what's your problem? No gravity, all your blood vessels get kind of weak, and yeah. Christina Science Cast. Was that really? Are you just making that up? So yeah, again, now I'm getting off target, but it's kind of cool. So we are not going to get anybody to Mars unless we can create gravity in some way, form, or fashion, because your blood vessels could not handle 0G. They just atrophy. They would just get weak. They're just one of the things in physiology. You need stress in your life. Gravity is a stressor. And so the biggest problem we would have is if we sent somebody to Mars, as soon as they got exposed to gravity, all their blood vessels would just like freaking, lose it. So we need some way to create gravity in 0G. That's why the most, so the most, I'm the worst person you want to watch a sci-fi movie with in a theater, or anything to do with science, because I just said nope. No, Andrea, and I will explain that when we get to the respiratory system. I will answer that question about diving, because I'm a certified scuba diver, and I'll explain that, but that's a totally different thing. All right, so if you want to watch the most scientifically accurate blockbuster movie, you watch The Martian. Has everybody seen The Martian? We can, for extra credit. We're all going to go watch The Martian, because I can't find any. The storyline might be a little silly, but the science is spot on. And if you notice, if you've watched that movie, they have a gravity thing. They have the circular thing, like centripetal force, that creates gravity, and you have to have that. Otherwise, our bodies couldn't sustain that. So. And we got makeshift things now, so we're not even close to being where The Martian was. So what do we use now on the International Space Station? We use bungee cords. That can work. All right, now I'm getting off topic. Let's move on. We'll watch The Martian. There may be an extra credit. I just sound like Elmer Fudd. Extra credit question from The Martian that has to do with physiology. All right. Okay. But like I said, if we're going to go to Mars, we need something that spins around and spins around. All right. Let's finish this up for the night. So again, veins get blood back to the heart, as we know. But again, it's one of those things where the heart can't push enough pressure to make the blood actually circulate all the way through. So they need a lot of help. So we have large diameters to reduce the radius, to reduce the resistance, because we have low pressure. We have one-way valves that only go to the heart. You can't go backwards. All right? So again, our veins have large lumens, very low pressure to work with. So we want to reduce the resistance. Lots of compliance means they stretch. And when you're relaxed under parasympathetic, 2/3 of your blood are on the venous side. That changes when you exercise, but if you're just chilling, most of your blood is on the venous side. Remember, and here we go, folks. If you remember way back when we talked about cardiac output, we started with venous return. More venous return, the more the left ventricle, or the EDV increases, the more stretch, Starling's law, boom. So we have to get blood back there. And so primarily, very good, snap the rubber band. Exactly, that's Starling's law in a nutshell. So we got to get blood back to the atria, and most of it is right here. Skeletal muscle pump. Venoconstriction when you're exercising. To some degree, we use what we call our thoracic thing, and I'm not going to make a big deal. I'm not going to ask you about this, but just think about this. When you take a deep breath in, you put a lot of air in your lungs. That's a lot of air pressure, and it pushes the blood out of the lungs back to the heart. When you exhale, you create a tiny little vacuum, and that draws blood back to the lungs. And so, but by far, It's the skeletal muscle pump. And again, this is how we really get blood back to our heart. All right. We have our veins. They have one-way valves. We contract our skeletal muscles. They squeeze on the vein and it pushes the blood forward. It can't go back. How many of you, let's get a poll here. How many of you have been in a choir or a band or a drill team or the military? Oh, Christina, none. Samantha, none. Andy, what were you in?
I was in drill team and I played the saxophone.
Okay, so what did you learn for any of you? What don't you do if you're having to stand for a long time? What did they tell you not to do?
Don't lock your knees.
Very good, Andy. Don't lock your knees. And again, now you guys understand. I know Katie's being a little jokester tonight. So now you know the physiology. Now you know the physiology. If you lock your knees, you're not using your skeletal muscles. So the blood that are in your legs can't push the blood back up to your heart. So all the blood pools in your lower limbs, your legs, because you're not using your muscles. You need to contract those skeletal muscles to get the blood back to your heart. So if you lock your knees, what happens, Andy, after a while?
You'll faint.
You'll faint. You'll faint because you can't get enough blood back to your brain. The heart doesn't have enough blood, not enough venous return, and especially if it's hot outside, because again, what you've learned is if it's hot outside, you're going to have vasodilation. So now those veins in your legs are going to be dilated and all the blood's going to be down there. And and trust me, after all my years in the military, when we had a big thing outside, when we had to stand at attention, they would have 3 or 4 ambulances in the back because people would faint. But now you know why. Now you know why. You lock your knees, no skeletal movement, no blood return to the heart, brain starves of oxygen, and you faint. All right, so now you know physiology behind that. They didn't teach that in choir school. All right, we're going to stop here, folks, and call it a night. Any questions? All right. So what did you, okay. And we'll have a little bit of a test review. Because I want to make sure that you guys are paying attention and taking notes on what I told you was going to be on the test. And I'll just save that for Monday. Christina's got some of this. All right. But like I said, if you're taking notes, you should have stars next to the things I told you were definitely going to be on the test. All right. And we'll do a little bit of a test review to make sure that everybody's paying attention to what I say. But if that's it, have a wonderful Wednesday. Christine, you're killing me. You're killing me, Christine. Oh, you got a great sense of humor. All right. Fun class. You guys I love the sense of humor of this class. All right. So have a wonderful Wednesday night. Study, and I'll see you Monday. Take care. Uh-oh, Andrea has a question on that. What is it, Matt? What is it, Ann? Okay. That's it. We got it. We nailed it. Perfect. Okay. All right. Christine, you have a question?
Yeah, so will we finish this lecture and then move on to blood on Monday?
Yeah, the blood is a very short lecture. It's nowhere near as long as this vascular stuff. So we can finish up the vascular and the blood on Monday with